Welcome to this Masterclass Explainer. Today, we're diving into a fascinating and highly testable topic for the MSRA exam, eosinophilic granulomatosis with polyangiitis, or EGPA for short. I'm super excited to guide you through this complex disease. We're going to break it all down into structured, easy-to-digest pieces so you can absorb the info rapidly, and more importantly, recall it in a flash on test day. Here is our roadmap for today. We've got 1. Overview and evolution. 2. Multi-system features. 3. Diagnostics and ANCA. 4. Management strategy. And we'll wrap up with 5. A rapid-fire MSRA quiz. Let's jump right in. Section 1. Overview and evolution. Demystifying the disease. So eosinophilic granulomatosis with polyangiitis is a rare, systemic, small to medium vessel necrotizing vasculitis. I know, that is quite the mouthful, but you can really just break it down by its key drivers: prominent blood and tissue eosinophilia, severe asthma, and granulomatosis inflammation. Now, what's incredibly important here is its historical name, Churg-Strauss Syndrome. Definitely lock that into your memory. Those older naming conventions still pop up in clinical practice all the time, and they are classic distractor options on exams. You absolutely must recognize both terms interchangeably. EGPA doesn't just hit a patient all at once. It actually has a classic triphasic clinical evolution. Let's look at the timeline. Phase 1 is the prodromal phase, which can literally go on for years. This is characterized by the onset of severe, incredibly difficult to control asthma during adulthood, often accompanied by allergic rhinitis or nasal polyposis. Then, moving into a timeline of months, we enter Phase 2, the eosinophilic phase. Here we see peripheral blood eosinophilia and eosinophilic tissue infiltration causing organ dysfunction, most notably things like pulmonary infiltrates and gastroenteritis. Finally, progressing over just weeks, we hit Phase 3, the vasculitic phase. This is the severe, systemic, small vessel vasculitis featuring constitutional symptoms like fever and weight loss, purpura, and a very specific nerve condition called mononeuritis multiplex. It's a pretty incredible and dangerous transformation from localized asthma to a severe systemic disease. Section 2. Multi-system features. The core triad. What's really fascinating about this disease is how it manifests across the body's systems, but it's always anchored by a very specific triad that you absolutely need to memorize. So grab a pen because this is crucial. It's the A-E-V mnemonic. A is for asthma, specifically adult onset and severe. E stands for eosinophilia, found in both peripheral blood and tissues, and V is for vasculitis, showing up as mononeuritis multiplex and purpura. Lock this into your brain for rapid recall. If an exam vignette has these 3 elements, your mind should immediately jump to EGPA. Mapping this AEV triad across the patient's body, we see respiratory involvement where asthma is present in literally 100% of patients. Neurologically, we get that mononeuritis multiplex. Think of asymmetric peripheral nerve ischemia resulting in a sudden foot drop or wrist drop. Dermatologically, you want to watch out for palpable purpura, which is a cutaneous leukocytoclastic vasculitis. But listen, I really want you to pause and focus closely on the cardiovascular piece here. Eosinophilic myocarditis, pericarditis, and heart failure can occur. And cardiac involvement is the leading cause of mortality in EGPA. Actually, I'm going to repeat that because it is a massive high-yield fact. Cardiac involvement is the leading cause of death. Section 3. Diagnostics and ANCA. Confirming the suspicion. Okay, so you suspect EGPA. How do you officially confirm it? To achieve high diagnostic specificity under the ACR classification criteria, you need to identify at least 4 of these 6 features. First up, asthma. Second, eosinophilia greater than 10% on the differential white blood cell count. Third, mononeuritis multiplex or polyneuropathy. Fourth, migratory or transitory pulmonary opacities on a chest X-ray. Fifth, paranasal sinus abnormalities. And sixth, a biopsy showing extravasculated eosinophils in blood vessels. Check off at least 4 of those boxes and you've got your confirmed diagnosis. Now, this right here is a classic trap that trips up so many test takers. EGPA is classified as an ANCA-associated vasculitis, but surprisingly, unlike other vasculitises in this family, only about 40% of EGPA patients are actually p-ANCA positive, specifically anti-MPO positive. That means a whopping 60% are negative. So a negative ANCA test definitely does not rule out the diagnosis. Please do not let an examiner trick you on that. Building on that, you must keep GPA and EGPA straight, because this differential is an absolute favorite for examiners. Granulomatosis with polyangiitis, formerly Wegener's, is predominantly c-ANCA, or PR3, positive. EGPA, on the other hand, is p-ANCA or MPO positive in that 40% subset we just talked about. But the crucial takeaway? EGPA is marked by severe asthma and marked peripheral blood eosinophilia, which are typically completely absent in classic GPA. All right, Section 4, Management Strategy, Protocols for Remission. The therapeutic approach here involves two very distinct phases, induction and maintenance. For inducing remission in severe or life-threatening disease, the absolute backbone of your therapy is high-dose oral or intravenous corticosteroids, like prednisolone. Now, if there are major organ-threatening manifestations, such as that deadly cardiac involvement, central nervous system disease, or severe mononeuritis multiplex, you've got to bring out the big guns and add cyclophosphamide. Alternatively, take note of the biologic agent, mepolizumab. It's a targeted anti-IL-5 monoclonal antibody, approved as a steroid-sparing biologic for relapsing or refractory non-severe EGPA. Once remission is successfully induced, we step down to maintain it with agents like azathioprine, methotrexate, or mycophenolate mofetil. And now for the fun part. Section 5, Rapid-Fire MSRA Quiz. Test your knowledge. Okay, it is time to put all this structured learning to the test with high-yield practice questions drawn directly from the material we just covered. Let's keep the energy high. First up, a 45-year-old man with a 5-year history of severe adult-onset asthma presents with fatigue, weight loss, new-onset foot drop, and high eosinophils. What's the diagnosis? Think back to our AEV core diagnostic triad. It's EGPA. Next, what is that specific peripheral nerve deficit characterized by asymmetric loss, like a foot drop, called? The answer is mononeuritis multiplex. And third, unlike granulomatosis with polyangiitis, which is p-ANCA positive, what type of ANCA is found in a subset of EGPA patients? The answer is p-ANCA, specifically anti-MPO. Moving right along, what organ system involvement represents the leading cause of death in EGPA? We hammered this home earlier. It's the cardiovascular system, typically via eosinophilic myocarditis or heart failure. Next, what degree of peripheral blood leukocyte differential is required for those diagnostic criteria? It needs to be greater than 10%. Do you remember the historical eponym EGPA was previously known by? It's Churg-Strauss Syndrome. And finally, for this batch, if a patient has rapidly progressive cardiac dysfunction and severe mononeuritis multiplex, which cytotoxic immunosuppressant is indicated alongside high-dose steroids for induction? Because it's severe and organ-threatening, the answer is cyclophosphamide. Let's bring it home with the last three. What classic cutaneous finding presents as non-blanching raised purple spots on the lower limbs? That would be palpable purpura. Which monoclonal antibody targeting IL-5 is utilized as a steroid-sparing agent in relapsing or refractory non-severe EGPA? That's our targeted biologic, mepolizumab. And lastly, while both EGPA and GPA are ANC-associated vasculitis, which key clinical respiratory feature present in EGPA is typically absent in classic GPA? The answer is severe adult-onset asthma, along with marked peripheral blood eosinophilia. Excellent job working through those. As we wrap up this explainer, I really want to leave you with a thought to bridge your exam prep directly into your everyday medical practice. Think about it. How will mastering these nuances change your clinical vigilance the next time an adult patient presents with seemingly standard but incredibly difficult to control asthma? By keeping that AEV triad and the threat of systemic vasculitis in the back of your mind, you might just be the clinician who catches a rare, life-threatening condition before it ever enters that dangerous vasculitic phase. Thank you so much for joining me in this structured dive into EGPA, and keep up the fantastic learning.